This is Dr. Daniel Quinn from Newton-Wellesley Orthopedic Associates. What you're about to watch is a knee arthroscopy with a partial medial meniscectomy. This is a very common problem that we encounter regularly in the office. Patient comes into the office with pain on the inside of their knee after an injury, and this is oftentimes the problem that we encounter. What you're looking at is my probe probing the meniscus, and you can see all that damaged area in the back of the knee. This area here is not damaged, and it's just the area where the meniscus is attached to the knee. Now we're looking at the second meniscus. This is the lateral meniscus. The first meniscus was the medial meniscus. This is the lateral meniscus, and this is normal. You can notice that the edge is very crisp and sharp. It's very smooth, C-shaped structure. It provides cushioning. It provides stability for the knee. This part here is just a quick view of the underside of the kneecap. So what do we do with this? Well, the likelihood of this particular structure healing, as you can see, is fairly nil. So what we end up doing is we end up trimming a portion of it out. It's the single most common knee arthroscopic operation done in the United States. It's very common problem, and it's very uncommonly symptomatic, and it can hurt. It hurts on the inside of your knee. So the shaver here is a device that has some teeth on it, and it has suction, and it has an oscillating blade that oscillates back and forth on the inside, so it suctions a portion of the meniscus in and trims it off. You can see already that what we're looking at is a much smoother structure. Now the key to this is the partial part. You don't take the entire meniscus out. That has been demonstrated fairly consistently to lead to a significant increase in your risk of arthritis. So our job is to preserve as much meniscus and cushion as possible, and yet remove the portion that is not working. And so this is another device that we use. It's called a biter, and of course it makes sense because if there are pieces of the meniscus that aren't going to enter the shaver and get trimmed, it requires the use of another instrument to take pieces out of the meniscus and make for a nice smooth margin of the meniscus. So once we've done that, then we put the shaver back in and trim again. And we're getting again closer to what will be the final product. And the overall approach that I take is where I leave as much good meniscus behind, but I certainly want to take everything that I think is going to hurt or might re-tear in the future. And it takes a bit of practice, but eventually you can get to a final product that's nice and smooth. This last instrument is a cautery, just to put some of the final touches on the partial removal. And you can see there's still a fairly good percentage of the meniscus remaining. There's a portion in the back that you can't see very well, but I've probably removed maybe 15 or 20% of the meniscus at this point. And as you can see, it's much smoother than we started. And I can say that this patient recovered very nicely. He was on crutches for a few days, and we had him back to full activity within about 2 or 3 weeks. So you can see it's a fairly straightforward operation, very routine. And what I'd like to think is that there's nothing that we do that is minor, but there's certainly things that we can do that are fairly simple that are generally very effective at helping patients return to their full activity level. And again, if you have any problems with your knee, you're worried that you might have torn your meniscus, this is potentially one of the options that you can use to help someone return to their activities without any restrictions.